Hi, I'm Dennis Nash, and this session is on the history and public health burden of infectious diseases. In this session, we'll cover the history of developments in the understanding of disease causation. Indeed, it was out of a desire to understand the causes of disease that the field of infectious disease epidemiology and epidemiologic methods emerged. Next, we'll cover the public health burden of infectious diseases and emerging infections with reference to the current SARS-CoV-2 pandemic, and we'll close with an overview of the course. Infectious disease and associated epidemics have occurred throughout recorded history. Here you can see evidence of polio from Egyptian hieroglyphs as early as 3700 BCE, and also evidence of smallpox on the mummified remains of Ramses V. In ancient Greece, the plague of Athens killed 33% of the population. It was thought to be due to influenza or Rift Valley fever. Across Europe in the 1100s, bubonic plague killed 90% of the population, and a subsequent wave in the 1300s killed 24 million people, including about 30% of Europeans. Bubonic plague spread by merchant ships carrying rats and fleas infected with the plague bacillus, and it's an early example of the relationship between travel and commerce and the spread of disease. We'll see many more of these. Later, in Europe, syphilis, a sexually transmitted infection, spread in the 1490s, and in the absence of antibiotics, this caused millions of deaths. At the time, the treatment for syphilis was a protracted regimen of the highly neurotoxic metal mercury, and the saying went, one night with Venus, and the rest of your life with mercury. It's hard to believe, but despite the fact that so many were killed and otherwise affected by these massive epidemics, our understanding about the causes of disease would not really advance for quite some time. But the recognition of these diseases as public health problems and that their occurrence might be preventable is what drove people to understand more about the causes of disease and death. So in many ways, it was out of that desire to understand more about the causes of disease that the field of epidemiology was born and reached its current form today. So epidemiology is the study of the distribution, causes, and determinants of health-related states or events in specified populations, and importantly, the application of this study to control health problems. So we're interested in things like what causes disease X? Does exposure A cause disease X? And can we prevent disease X from occurring? So this is what defines the field of epidemiology today, but how has our understanding of the causes of disease evolved over time, particularly before the advent of the field of epidemiology? Well, we can look at what we've learned about the causes of disease over the centuries, or how at least the cause of disease was understood in different times. So one common theme is that disease and death were brought about by the wrath of God. And here's a quote from the Bible that says, "For now I will stretch out mine hand, that I might smite thee and thy people with pestilence," from Exodus. And you can see this theory about supernatural causes of disease in this 19th century painting depicting the horror of a plague outbreak ravaging Rome, where an angel comes down and points to the next house or points to the house where the next case of plague should occur. Again, alluding to the fact that it was really determined by supernatural forces what would spread the disease through a population and who would be affected next. But that's not to say that there wasn't evidence of rational thinking about the causes of disease as well. As early as 400 BC, we can see in Hippocrates' writings in the Epidemics that he rejected this notion of supernatural causes of diseases. In fact, he related symptoms of different illnesses to seasons and geography and soil and nutrition. One thing that wasn't quite right at least with regard to infectious diseases, is that he focused on illnesses and sick persons as unique events, not necessarily related to one another. But we know, in fact, with infectious diseases that one person's risk can be very influential for other people's risks in populations. Importantly, he also coined the terms endemic and epidemic, which are terms that we will define formally in the course. In some ways, without the field of epidemiology to serve as a guide, it's understandable that the causes of disease and outbreaks were sometimes not immediately obvious. The causes of disease are often complex and involve multiple steps and actors. For example, in the case of bubonic plague, When an infected rat is introduced into the household, other rats are quickly infected by the fleas that infest and feed on them. However, since the rats die, and also the plague bacillus prevents the fleas from digesting the rat blood, the fleas begin to look for other sources of food, like humans. And when plague-infected fleas bite humans in a given household, plague ultimately kills 50% of household residents over the course of a few weeks. Another 1 in 4 household members are infected but survive, and the final 1 in 4 don't become infected. We know this now, but the role of rats and fleas were really not appreciated as a cause of bubonic plague, even though large numbers of rats were observed to coincide with plague epidemics. This late 17th century painting depicts the bubonic plague. It conveys the fear, abandonment, loss, and uncertainty and pandemonium that must have accompanied the plague outbreaks at the time. But it also conveys this lack of understanding about the causes. At that time, it was thought to be caused by noxious air, not the bite of an infected flea. You can see here in the picture the dark cloud of noxious air circulating in the room, and also people covering their noses and mouths with a cloth mask. That diseases like plague and cholera were caused by noxious air was a prevailing medical theory of the times, known as the miasma theory. But clearly there was a notion of person-to-person spread of diseases in the time of plague. Though this was not how bubonic plague was spread, authorities acted on their hunch in Venice around plague by boarding incoming ships that were coming into port and identifying ill people and preventing them from disembarking. And this is an early example of the strategy of isolation. They did this by routinely looking for possible plague cases or surveillance, and they did it for the purposes of controlling and preventing disease in the community, which is a public health intervention. Eventually, authorities prevented all persons, regardless of whether they had symptoms, from disembarking from these ships coming into port in Venice, and waited to see if they developed illness. And they did this for a period of 40 giorni, or 40 days in Italian, and that is the genesis of the term quarantine. So these two different strategies, isolation and quarantine, are important public health measures to control the spread of infectious diseases. And the distinction is that isolation focuses on people who are ill with symptoms or known to have the infection, whereas quarantine focuses on all persons who may have been exposed to a given infection. So while the communicable nature of diseases was appreciated, the epidemiology and mechanisms were not well understood, and this led to flawed disease control interventions. For example, the focus on isolation and quarantine for bubonic plague when it was really being spread by rats and fleas. But I hope this gives you a sense of how fundamentally important it is for us to understand causes of disease and disease spread so that we can adequately design the interventions and strategies that help us attain the critical public health goals of disease prevention and control in populations. Fracastora was one of the first to hypothesize that infections were spread from person to person by minute invisible seeds or seminaria that were specific for individual diseases. He said that they were self-replicating and acted on the humors of the body to create disease. This was prescient thought, right? But he also was a little bit off by saying that these seminaria were related to planetary alignment and not necessarily microbes that we know they are today. All of these hypotheses and theorizing about the causes were happening prior to germ theory. So before it was known that there were microbes and living organisms that were the cause of different diseases. And he went on to also posit that there would be 3 modes of transmission of these seminaria: person to person, fomites, and airborne. Fomites being inanimate objects on which the seeds, in his case, or actual microbes could be conveyed from a source to a susceptible individual who could become infected. So these were pretty important conceptual developments in the 1500s. In the 1600s, Thomas Sydenham hypothesized or argued that all diseases ought to be reduced to certain and determinate kinds, similar to the way that botanists would do with their treatises of plants. Many of you have probably seen these detailed drawings of plant species that really help distinguish between or help differentiate between one species of plant and another. He thought the same should be true for different diseases. And along with that, he thought that diseases would have their own, would be distinct in and of themselves. And that spurred thinking about how diseases might also have distinct causes. So this was an important development. Another important development in the 1600s was when Petty and Grant began to use data to describe patterns of mortality. This was thought to be one of the first applications of statistics. And they went around and they gathered information from each parish in London on the bills of mortality that each parish would publish, say, on a weekly basis, to tally the number of births and deaths, and in some instances, even the causes of death. After doing this, they realized how important it could be, and they proposed the establishment of a central government agency to do this going forward, to collect data on vital information on births and deaths. And they published a very important book on the observations, entitled on the Observations on the Bills of Mortality, where they analyzed these data and presented their results. So just to give you a sense of how this worked, each parish would routinely post bills, written details on the number of people who were born and number of people who died in the parish. And these bills would be gathered and compiled. The data would be summarized here and in a statistical fashion, right? So here in the year being 1632 in London, they reported that there were 9,584 people christened or born, and 9,535 buried or died, whereas 8 were of the plague. So only it was a slow plague year, only 8 deaths in all of London. But there were other causes that were more common, such including infectious causes. You can see here consumption. There were almost 1,800 of these deaths were thought to be due to consumption, which is tuberculosis. And another 1,100 or so were due to fever, which could be a variety of different infectious causes. Here we have flocks and smallpox, 531. And using the data that they compiled from all the different parishes in this way, they were able to make observations such as 36% of live births resulted in death by age 6, or that males were more likely to die from violence, war, and other causes compared with females. They could analyze time trends and the number of deaths in London over the preceding third of a century to look at the seasonality of deaths. And they could also compare mortality rates by urban versus rural, again, getting insights about what might be some of the underlying causes. In the 1700s, Morgagni used autopsy studies where there were detailed accounts of the symptoms that people were experiencing before they died, and then investigated on autopsy. It was possible to correlate the signs and symptoms observed in the patients while they were alive with the specific pathological changes in the tissues and organs that occurred after they had died on autopsy. And this was another example that spurred sort of the search for specific as opposed to general causes of diseases. So each disease could have its very own specific cause, since each disease has its very own specific set of symptoms and pathology. Another important observation is with regard to smallpox or variola. Smallpox infection was observed to confer immunity among its survivors. While it killed most people it infected, those that survived did not appear to be at risk for becoming infected with smallpox in subsequent exposures or outbreak situations. And so people would take the scabs from smallpox survivors and use them to inoculate in themselves as a kind of way of protecting them It's an early example of this notion of vaccination, or I think it was called variolation, that was done in Africa and China and India. Later, Edward Jenner had the observation that milkmaids, people who milked cows, were immune to smallpox infection. And this was possibly, he hypothesized, because they were exposed to the cowpox virus or vaccinia. And so he did an experiment whereby he inoculated an 8-year-old boy with the cowpox virus. And then, after adequate time passed to develop an immune response to the cowpox virus, he exposed the boy to smallpox virus to see if he would develop smallpox infection. This is obviously an experiment, a challenge experiment that would be, highly unethical by today's standards, but it was done, and luckily it worked. The boy did not develop smallpox. And the science of vaccination was born by Jenner's first vaccination clinical trial, although the practice had been going on probably for centuries in Africa, China, and India. But smallpox, which killed about 300 million people in the 20th century alone, was eventually eradicated using vaccination. In the 1800s, that recommendation that Petty and Grant had put forward about establishing a central government office to register birth and deaths in the 1500s didn't quite happen right away, but by 1831, the government of England saw fit to establish such an office. The General Register's Office of England was headed up by William Farr beginning in 1838, and this office was responsible for capturing information on all recorded births and deaths. Farr also developed a disease classification system that was a little bit more systematic than the one we saw on the observations in the bills on the bills of mortality. There were broad groupings here, and the infectious diseases largely fall into this category called zymotic diseases, which were epidemic, endemic, and contagious diseases. And there were other groupings, as you can see, different organ systems and violent deaths. And importantly, he would disseminate these findings to the general public on a regular basis. So here's an example of the 20th annual report from the Registrar General's Office on births, deaths, and marriages in England in the year 1859. And I don't want you to get all of the details in the table, but just to give you an idea of its structure here, on the in the columns going across are the year running from 1850 to 1858. And going down on the rows here are the different causes of death. So zymotic diseases, constitutional, local, and violent, et cetera. And you can see in each of these cells are the number of deaths in each year from all causes, ranging from 300 to 400,000 deaths, or from 300 to 500,000 deaths. And then each one broken down by cause, so you can get a sense of which were the more common causes of death in England in a given year. And I just want to highlight that this is another table that comes from our New York City, our health department here in New York City, and their annual report on vital statistics that they put out each year. And the table format that Farr used back in the 1800s to summarize this information really still does endure today. It's the same format. What's different now, of course, is our disease classification system, our death classification system. It's more precise, it's more accurate, and more evolved. But the basic structure is the same. And these kinds of statistical summaries of mortality really help us understand what the major causes of death are in populations, and they can be used to set public health priorities for disease prevention and control. Next, we're going to transition from early thinking about causes of disease in individuals to more like epidemiological thinking around causes of disease in populations. Indeed, this was the logical next step, since it was increasingly common for people to have theories about the causes of disease that couldn't really be tested without observing what happens with disease spread in populations. Since you're in an infectious disease epidemiology course, I'm sure you've heard of John Snow, and his discoveries around the cause of cholera, which gave birth to the epidemiologic method in the process. Cholera was a major cause of death in England in the 1800s, and Farr and Snow were contemporaries and did much of their work prior to the advent of germ theory. The germ theory being the theory that microorganisms too small to see with the human eye were the cause of infectious diseases. So William Farr, the general registrar, believed that miasma, or bad air, was the cause, and John Snow, an anesthesiologist, was a skeptic of miasma as a cause of cholera. At the time, Farr argued that even if the ultimate cause of an epidemic is not known, the mode in which the epidemic operates could be determined through observation with the potential to ultimately prevent or control epidemics. And this is exactly what John Snow set out to do. Using the death registration information gathered by Farr, Snow described the London outbreaks of cholera as being associated with a contaminated well on Thomas Street and a burst drain from Albion Terrace, culminating with an account of 89 deaths from cholera among persons drinking from the Broad Street pump. People who died had drunk from or bought water from the Broad Street pump, and those who had other sources of water or drank beer, like the workers adjacent to the brewery there, did not get cholera. So importantly, he investigated what was going on in those who had the disease as well as those who did not have the disease. And from this observation and the knowledge that the water was supplied to Londoners from different water supply companies, Snow generated a hypothesis. The source of water, or the water company, is associated with the risk of death from cholera. In fact, a better scenario couldn't have existed for Snow to test this hypothesis because in many cases, two adjacent households would receive water from different water supply companies. And he immediately grasped the strengths of the natural experiment that these circumstances provided. And in Snow's words, he said, to turn this grand experiment to account, all that was required was to learn the supply of water to each individual house where a fatal attack of cholera might occur. For each district, Snow compiled the deaths from cholera in 1849. He combined that with information on the number of people in the population living in each district to compute a rate of cholera deaths per 10,000 inhabitants. Finally, he noted the water companies that were supplying the water to each district. So you can see here that the number of cholera deaths per 10,000 inhabitants is calculated, and the table is sorted from high to low on that number. And then information on the exposures, the water supply company for each district is given here. And this is just showing the remainder of that table, sorting all the way down to the district with the lowest cholera death rate. Overall, there were about 2.2 million people living in London in 1849, about 14,000 deaths from cholera for a number of 62 deaths per 10,000 cholera inhabitants across the entire city. So you can see how it really varied from one district to the next. And Snow compiled this information, the deaths from cholera, and ultimately looking at it at the household level, and compared the death rate per 10,000 households for the Southwark and Vauxhall Company to that of the Lambeth Company. And you can see that there was quite a big difference here and in the rate. And just showing that same information graphically, the households that were served by the Southwark and Vauxhall Company had cholera death rates that were an order of magnitude higher than the households that were served by the Lambeth Water Company, as well as those serving the rest of London. It turned out that the Southwark and Vauxhall Company water supply company got their water from the Thames River downstream of London, along with all the sewage from the city, whereas the Lambeth Water Supply Company got its water from the Thames River upstream of the city, with the Thames River, of course, flowing in this direction. And so without the advantage of germ theory and laboratory methods, Snow was able to isolate the source of water as a cause of the cholera outbreaks. He was really a pioneer in the development and application of epidemiologic methods when he used them to identify these this downstream cause of the cholera outbreak and ultimately eliminate it by the symbolic removal of the Broad Street pump handle. He hypothesized about an exposure, contaminated water in this case, and then systematically compared the risk of the outcome, death from cholera, in those exposed and unexposed, thereby giving birth to the epidemiologic method. So, John Snow, who studied these great cholera epidemics in London during the 19th century, said, but all of the above circumstances are quite sufficient to show that cholera can be communicated from the sick to the healthy. For it's quite impossible that even a tenth part of these cases of consecutive illness could have followed each other by mere coincidence without being connected as cause and effect. In fact, much of our understanding of disease causation and epidemiology today is actually rooted in the experiences with infectious disease outbreaks. And I just want to highlight again that this was done prior to germ theory, showing that it's really possible to prevent disease and outbreaks even when the biologic agent is unknown or not thoroughly understood. And this is what Farr meant, I think, when he said, if the latent cause of epidemics cannot be discovered, the mode in which it operates may be investigated. The laws of its action may be determined by observation, as well as the circumstances in which epidemics arise or by which they may be controlled. Indeed, germ theory didn't emerge until 1876, when Koch reproducibly transmitted anthrax from cows to mice. Germ theory and microbiology began to elucidate what Sydenham and Morgagni posited much earlier, that specific pathogens were associated with specific disease entities. The discovery of germ theory promoted the biologic understanding of infectious disease processes in very significant ways. And subsequently, the Hennecock postulates were developed to use and used to provide proof that a particular microorganism is the cause of a particular infectious disease. And these were later generalized to assess the level of evidence for causal associations in epidemiology. This slide shows the year in which different organisms were physically isolated and identified as causes of specific diseases. The bacteria that causes cholera wasn't identified until 1883, after Snow's death. And if you've ever wondered where the E in E. coli comes from, E is short for Escherichia, and it's based on the name of the bacteriologist who discovered it, Theodore Escherichia. So next, we're going to focus on historical developments in the United States related to mortality and morbidity monitoring. There was a study by Lemuel Shattuck that related death and other outcomes to living conditions in Massachusetts, and this was considered one of the first applications of social epidemiology. To do that, of course, you need denominator data like Snow used for calculating death rates due to cholera by district, and recommended establishing a decennial census in the United States. So this was an important development, and that helped our ability to be able to do more useful things with morbidity and mortality data. Prior to 1850, for mortality monitoring, states and local jurisdictions began conducting death registrations. They sort of did it on their own. It really wasn't, coordinated nationally or federally. But by 1850, there were attempts to compile mortality statistics nationally based on the death registration that was happening within each of the state and local areas, and using the census data. So this slide is from New York City specifically, and it shows the all-cause death rate over time. You can first see that it goes all the way back to 1800. So New York City was doing vital statistics and vital registration, monitoring mortality causes of death as early as 1800. But this particular graph goes all the way out to 2017. It comes from the cover of the Summary of Vital Statistics report that the City Health Department puts out every year. Um, so yeah, as I mentioned, I really like this graph because it contains so much history and information about mortality in New York City. But even more than that, of course, going back all to the 1800, you can see that that was a time when there were only about 120,000 people living in the old city of New York. But over time, you can see how the population of New York City increased and reached its ultimate uh, total of more than 8 million people today. On the y-axis, what you see is the deaths per thousand population, and these are deaths due to all causes. So regardless of what the person died from, it's counted here. And what you can see is how volatile the death rate, all-cause death rate was, in these early years. Um, Here listed are different years and numbers of deaths that were caused by different infectious disease outbreaks. So in 1832, there were 3,500 deaths in New York City due to cholera. In 1849 and 1854, similarly, a large number of deaths due to cholera. These were the years that there were also very large outbreaks of cholera in London that John Snow was investigating, and it highlights the connection between the two cities and how when there are connections between cities, there also can be connections around disease and disease spread. Um, but you can see the very large peaks. In some instances, the death rate nearly doubled from as a result of a particular outbreak. And moving along in time, you can see that this volatility begins to become less and dampened. And but we do see this pretty large spike again in 1918, and this is 1918 pandemic H1N1 flu that killed about about 12,500 people in New York. And also, just to put a couple of things on the radar here, things continued to decline over time. We began to see the peak in the HIV death rate in 1994 in New York City with 7,000 deaths. And in 2017, influenza killed about 1,945 New Yorkers. So this slide is showing national data, the same sort of um, information, but starting from 1900. And the mortality rate is per 100,000 per year. And it breaks, this is showing the same trend that we saw in the prior graph, the all-cause mortality rate over time. But these two trend lines below it break that overall trend line into non-infectious causes in blue and infectious causes in pink. And what you can see here is that most of the decline in the overall death rate that we see in the US really is a result of major declines in the infectious disease death rates and not much changes in the death rate due to non-infectious disease. You can also see again here how the 1918 H1N1 pandemic flu fits in. Very big spike. It's something that we have always been concerned about happening again in the US, and now we're experiencing a pandemic of that same scale. And here you can also see that after reaching a historic low in 1980, we began to see an uptick in the infectious disease death rate for the first time in quite a while that was sustained, and that represents the HIV pandemic, its effects on the US. So this is now just zooming in on trends in the death rate due to infectious diseases in the US, going from 1900 forward, adding a few other things to the timeline. And you may be surprised, as I was when I was learning some of these things for the first time, getting my MPH, that a lot of the declines in the infectious disease death rate were happening, well before advances in modern medicine like antibiotics and vaccines came along. And so what that means is that these major declines in the death rate, which really drove declines in the infectious disease death rate, which really drove overall declines in mortality for the entire country, were due to things that were more like public health oriented and not due to advances in medicine. So improved sanitation and improved nutrition and living conditions and things like that. These are the things that we think of as public health impacts and achievements over the course of the 20th century that really brought down the death rates. You can see that health departments were established in the early 1900s in most states, chlorination of the water supply around the US as well. And I guess the last point about this slide is looking at the death rates over time. They tell you a lot about what's going on with regard to health in the population. But there's one thing that it doesn't really tell you about, and that is like this other issue of people who get sick due to an infectious disease or any disease, but don't necessarily die from it. So this would be more like this concept of morbidity. In addition to tracking like the causes of death and trends in the different causes of death, we also need to track what's going on with like people who are getting sick but not necessarily dying, because this contributes greatly to the burden of infectious diseases as well. So how do you track morbidity? It's a lot more complicated to track in many ways than mortality. Uh, it's fairly straightforward to count deaths, and maybe if someone is qualified to make an assessment, can even say something about what the likely cause of death might have been. But tracking, the extent to which people become ill is but don't necessarily die is much more difficult. And so how did this evolve in the US? How did this come about? Well, as early as 1741, one strategy was to ask tavern owners to report when their patrons had contagious diseases to health authorities. By 1874, the Massachusetts State Board of Health began requesting voluntary reporting of various diseases that were diagnosed by physicians. So physicians were expected to do the reporting of individuals that they diagnosed with certain diseases of public health significance. And in 1893, Michigan actually began to require reporting of these diseases, and this is because it's really probably the most reliable way that you can get regular information on these kinds of things is by changing the health code, enacting law that requires the information to get reported to health authorities. So these were all sort of state efforts, and by 1901, all U.S. states individually required reporting of some kind of reporting of specific infectious diseases from physicians to local health authorities. But this was not really nationalized or federalized until 1914. And the way that the federal government would get this information is they realized they had to deploy federal staff from the U.S. Public Health Service in state health departments who would be responsible for compiling this information and sending it off in telegraphs to the federal level so that they could track what was going on nationally. By 1925, there was full participation by all US states in weekly morbidity reporting. So what does morbidity reporting look like? Here's an example of a trend line that is showing cases of polio. So not deaths due to polio, but when the number of people, or in this case, the rate with which people are diagnosed with polio over time. And adding on the timeline here, they're including things that could be influencing the trend, such as when vaccines became available. And a more recent example, this is showing the cases of SARS-CoV-2 that resulted in hospitalization in New York City over time. This is another example of morbidity reporting. Every time there's a person hospitalized with SARS-CoV-2 in New York City, it is something that providers and hospitals are expected to report to the health department so that we can track what's going on with the epidemic. So these are examples of morbidity reporting that as distinguished from capturing information on deaths and the causes of death. So yeah, if you look sort of through the words scattered through this slide, you can see I've highlighted here words like mortality, morbidity, report, reporting, weekly, and monitoring. This has resulted in the creation of the MMWR that CDC produces every week in 1961. They began publishing the Morbidity and Mortality Weekly Report. That's what MMWR stands for. So it tracks both morbidity and mortality related outcomes for specific reportable diseases. You may be wondering who decides if a disease is reportable to CDC. And in fact, it's not the CDC, it is the state and local jurisdictions themselves that ultimately are authorized to require reporting in their own jurisdictions. But they do in collaboration with each other. An organization called the Council of State and Territorial Epidemiologists, or CSTE. They gather and work together to make annual recommendations about which diseases should be reported to CDC and published in the MMWR. So you'll find, in addition to routine morbidity and mortality statistics in each weekly MMWR, lots of interesting reports. So here's an example of a report on HIV testing on National HIV Testing Day in the June 27th, 2014 report, including a dispatch from New Orleans about their routine HIV screening program in comparison to one in New York City. When there are major outbreaks, both in the U.S. and also around the world, some of the first reports are often found in the MMWR. So this is a report from the on the Ebola viral disease outbreak in West Africa in 2014, and in 2015 and 16, the MMWR also contained some of the first reports of Zika virus spread in the Americas. And more recently, there was a very interesting and detailed report of the spread of SARS-CoV-2 at a choir practice in Washington State. And we'll come back to this, but basically this report recounted a choir practice with about 60 or 70 people in a church where one of them was infected on the day of the practice, and ended up spreading the infection to about 70 or 80% of the rest of the choir during over the course of a few hours. So an example of a super spreading event, and where we have an opportunity to really learn a lot about the properties of a given pathogen. But in every week's report, you can see some of the routine data that are captured. So here we're seeing the number of invasive meningococcal cases that were reported, and the number of pertussis cases that were reported for the US as a whole, and then for different geographic areas. You can see how many cases are being reported in a given week, and also how it is related to the previous 52 weeks, if it's higher or lower, and how it compares to the cumulative reports for the entire years preceding. There's also graphs and visualizations in the MMWR, sort of giving you a sense of, for a given week, are we seeing increases or decreases in the reports of certain notifiable diseases. And in this example, what we saw was an increase in the number of mumps cases reported that were beyond historical limits, suggesting that there was some kind of a mumps outbreak happening around the US. And here's an example of deaths. Every week, there's a table that includes deaths from 122 US cities, broken out by age, and also included are the deaths that are due to pneumonia and influenza, or P&I. So the MMWR is produced every week by CDC. It's free. You can download the PDF or view it on the website. You can also have the table of contents emailed. You can sign up for their email distribution every week. Given that you're taking the course, I would recommend going into the website and perusing a few recent issues of the MMWR, so you can get a sense of the kinds of information that is there. But also the fact that we're now in the middle of a pandemic, a lot of updates around SARS-CoV-2, both for the US and globally, are found in the MMWRs, and so it might be a good idea to just go ahead and subscribe, so you can keep an eye on what is coming out from CDC around the SARS-CoV-2 pandemic. So next, we're going to cover the public health burden of infectious diseases in the US and globally. So you can begin to gain a sense of how much of the overall burden of disease in populations is driven by infectious diseases as opposed to other causes of morbidity and mortality. So this slide shows the 10 leading causes of death in the US in 1900 compared with 1997, about 100 years later. And as you probably remember from the graph that we showed, that epidemiologic transition of big reductions in infectious diseases over time and not much change in non-infectious causes of death. This slide shows how the predominant causes, the top three causes were infectious disease related in 1900, but by 1997, those were replaced, and a much greater share of the deaths in 1997 were due to non-infectious causes. And we don't really get down to see an infectious cause until maybe the sixth cause here, pneumonia and influenza, and then followed by HIV infection after that. So you can get a sense of what this shift looked like in just the change in the ranking of causes of death over time in the 20th century. And this slide shows the mortality rate this time and showing how it has changed over time over in three years, 1900 compared with 1935 and 1970. So you can really begin to pinpoint, how much and when some of these declines happened. So pneumonia and influenza still a challenge, but has declined substantially from 1900, and also big declines in the rate of tuberculosis deaths and in gastroenteritis of things like cholera and other infectious diseases shown here. The prior slide showed the declines in mortality from infectious diseases, and there are at least two ways that mortality can decline, right? One is that the disease is less frequent or common. There's been a decline in the occurrence or incidence of the disease. And another is that treatment for the disease has reduced mortality, even though the infection or the disease itself is still occurring frequently in the population. So what this slide shows is that declines in morbidity, not mortality, for vaccine-preventable diseases also occurred, with major reductions. The take-home point here being that the incidence of these infections is a major driving force behind the declines in mortality. In fact, reducing morbidity from vaccine-preventable diseases is considered one of the major public health triumphs of the 20th century. So this slide shows the absolute number of deaths that occur each year, that have occurred each year in the US from 1990 to 2016. So you can get a sense that, between 2 and 3 million deaths occur from all causes in the US each year, and that this number has been increasing a little bit every year. And so, we can begin to think about why this might be happening. The size of the population is increasing, but also the population is aging. And just to put into context, so far in 2020, we have 187,000 COVID deaths in the US, and this number, of course, could go up a lot more before the end of 2020. But this is giving you a sense of how the contribution of the SARS-CoV-2 pandemic in the US to the overall number of deaths in the US. You can think about looking at the burden of disease in terms of number of deaths as well as the death rate, or the deaths per 100,000. And this is a slide that is showing the disability adjusted life years, or DALYs, and ranking the causes of death for the US between 1990 and 2016, and you can see how things have changed or not changed so much. The other thing that I like about this is a slide that's coming from the website of the Global Burden of Disease Project, is the color coding. The blue colors represent non-communicable diseases, the green colors represent injuries, and the red colored lines represent causes that are communicable or maternal, neonatal, and nutritional diseases. And so you can see at a glance that infectious diseases and are sort of down more towards the lower end, below the top 10 causes of disability adjusted life years. And you can get a sense of how they're changing. For example, so big changes in HIV and tuberculosis rates. Well, not so much big, but going from number 14 to number 16 between 1990 and 2016. So looking globally now, this slide shows that there are about, it's comparing the number of deaths estimated to have occurred globally in 2005 and 2015. So about 53 million deaths in 2005 compared to 55 million in 2015, about a 4.1 percentage increase over that 10-year period in the absolute number of deaths. And what we're also seeing here is that the age-adjusted death rate has gone down over that same time period. So what we're seeing is two things, right? We're seeing an increase in the number of deaths, slight increase, and a fairly substantial decrease, 17% change in the death rate after accounting for age. Why would these two things be, or how would you interpret these two statements together? And part of it has to do with the fact that the world population is aging, and so there's population growth in the older age groups. And so the age distribution has changed in the population between 2005 and 2015. But after you account for these differences in the aging structure and the overall population, the death rate actually has gone down. And so it suggests that there's progress at preventing death and prolonging life. But let's dig a little bit deeper on that. Looking globally, a similar graph, this is sort of showing a similar trend graph that we saw for the US, an increase in the number of deaths over this time, nearly 30-year period, from 46 million to 54 million per year, and a decline in the death rate over time. And I mentioned here the aging of the population, or sorry, the increase in the population, right? It nearly doubled between 1990 and 2013, right? So we have a very large increase in the number of people, and so this will help to increase the absolute number of deaths that occur because there are more people at risk of death. At the same time, the population age structure has changed, and this slide is showing a population pyramid, showing basically the age distribution for females on the left, for males on the right, and the younger ages and the lower end of the pyramid, and older ages at the higher end. And for the most part, you can see a sort of swelling that's beginning to occur in some of these older age groups, even as you look across different settings, so resource rich and resource limited settings, and then down here, sub-Saharan Africa. There's aging that's happening in addition to the increases in the population size. And for this reason, this is why we're seeing, this trend that is showing both an increase in the number of deaths, but also a decrease in the age-adjusted death rate, suggesting some of the progress that we're making in public health. So this slide is breaking things down a little bit further. It's showing the number of deaths in millions by age group. And when you look at how the number of deaths have changed over time, what you see here is that the story is a little different depending on the age group you're looking at, right? The number of deaths declined markedly in young children, whereas the number of deaths increased rapidly or substantially in older age groups. And during 2005 to 2015, where we saw that the age-adjusted death rate declined by 17%, the decline was greatest for communicable maternal, neonatal, and nutritional diseases as compared with non-communicable diseases and injuries. So you can see here there was a decline for communicable diseases, both in the number of deaths on the left and in the age-adjusted death rate on the right. So looking at this slide, it's showing now the absolute number of deaths by age group globally. And as you might expect, the distribution of the different causes of death vary by age group. In the neonatal period, the major causes of death include preterm birth and neonatal encephalopathy and neonatal sepsis. But during the first 5 years of life, infectious diseases like HIV and TB are common causes of death. In older age groups, non-communicable diseases shown in blue, such as cardiovascular diseases and neoplasms, tend to predominate. And this slide is now showing the death rate per 100,000 population, and you can see that proportionally now, younger persons and older persons to a certain extent are much more likely to die in a given year, and that the overwhelming majority of deaths among younger persons is due to the infectious disease group or infectious diseases, maternal and neonatal disorders, and nutritional deficiencies. And as we saw, disability adjusted life years are another way to think about disease burden and quantify disease burden. So if you take into account the fact that people with some of these conditions are living with more years of disability, you can see that when you look at the DALYs, it reflects both the number of deaths and the number of years lived with disability. It shows a really different picture than the prior slides. So the sum of the years lost and the years lived with disability, or DALYs, it really shows you that a lot of these disorders are affecting people throughout the life course, with the exception of, or maybe on the lower side among children age 5 to 19 years old. But you can see that the burden of disease is distributed throughout the population age structure, but that the things that are contributing to it are different. But with the focus on infectious diseases group shown in red, you can see while the other slides certainly demonstrated the impact in the very young children and neonatal period, you can now begin to see the contribution of infectious diseases throughout the lifespan, including in middle age and older age. And I'm going to walk you through another set of slides, just again, sort of giving you a sense of the relative burden of infectious diseases compared to other causes, depending on how you quantify burden. In this slide, it's just looking at the absolute number of deaths. So of the 54 million deaths that were estimated to occur in 2015, you can see the overwhelming majority of them were for non-communicable diseases, and the group of diseases of interest to us is this red pink group. The other thing that these graphs highlight, or these visualizations highlight, that I like is the darker shades indicate things that are increasing over time, and the lighter shades indicate things that are decreasing. So you can see that increases in lower respiratory infections and encephalitis are happening globally in the number of deaths. You could also look at this same slide using, instead of the number of deaths, disability adjusted life years, and you see a slightly different picture here. I'm just going to snap back and forth so you can see the size of the reddish rectangle gets a bit bigger when you look at disability adjusted life years, and that is reflecting this contribution of infectious diseases not only to death but to disability throughout the lifespan. And you can also compare the relative share of these things by setting. Here on the top, looking at the absolute number of deaths in resource-rich settings compared to resource-limited settings. And what you see immediately is that in resource-limited settings, infectious diseases and maternal conditions and neonatal causes of death, nutritional deficiencies account for a much larger share of both the absolute number of deaths as well as the number of years lived with disability, which is yet another way to quantify disease burden. And globally, we looked at this earlier for the US, and globally you can also get a sense here where infectious diseases rank or where they fall in the rank of causes of death. Here we're looking at rates of death per 100,000. And you can see that infectious diseases are represented in the top 10 causes of death, both in 1990 as well as in 2015. And now we're looking specifically in those areas of the world that are lower socioeconomic development index, and these you can see infectious diseases are contributing even more to the top causes of death. And the point of this slide, which really is showing trends over time in age standardized disability adjusted life years, looking at different settings from low socioeconomic development index to high, mainly here to show that while DALYs due to infectious diseases are higher in resource limited settings, they are at this stage declining in all settings in more recent years. You also may be wondering where some of the information on the occurrence of death and the cause of death for individuals come from, especially in areas of the world that are really resource poor and maybe don't have vital registration or don't have good ways of ascertaining and documenting the cause of death for people who die. This really does pose major challenges for tracking these kinds of things around the world. The Global Burden of Disease Project uses, where it exists, vital registration in the US, for example, and the cause of death that comes with death certificates. But in places where it doesn't exist, they use very complicated sampling algorithms and methods to try and infer what might be going on in areas where there's not good information coming out. And that also involves modeling, mathematical modeling, and statistical modeling to give you a sense of what might be going on. And the details of these methods are published elsewhere in detail. The main point I wanted to make for you all here is that there's uncertainty around these estimates, and this graph is showing the causes of death ranked by from highest to lowest. So this would be the number one cause of death up here, cardiovascular disease. And you can see that there's a 95% confidence limit around it. As you get into the number two, number three, four, and five causes of death, you can see that in some cases the confidence limits are overlapping with each other. So it suggests that the level of certainty that is conveyed in some of these graphs on rankings of causes of death, it's really, it's not so certain. It's possible that, the number five cause of death is actually the number four cause of death and things like that. But I just want you to come away from this looking at these data on the global burden of disease, that there is uncertainty in the estimates that we have on the burden. We've also been talking a lot about so-called causes of death, and in other words, what are people dying from? But as public health people and students in an epidemiology course, you also might be thinking about things like, what are the real causes of death? What do we do? What are the causes of death that we can prevent? What are the risk factors? And so another way of looking at these data on burden of disease is to sort of slice and dice it according to those risk factors. So what are the real causes of death? In other words, not necessarily heart disease or cancer, but things like tobacco use or alcohol or dietary risks. These are the factors that some of us in public health are more concerned with on a day-to-day basis, and we can get a sense quickly looking at the data of the proportion of disability adjusted life years that are driven by various risk factors, which is always important for us to keep in mind. So for example, you can see here that, or we just know that the best way to reduce DALYs due to mental illness or heart disease is to prevent those things from occurring to begin with. And that means a focus on risk factors. So you can get a sense quickly from this slide, what's driving the DALYs for infectious diseases. And these include globally things like malnutrition, tobacco use, air pollution, alcohol and drug use, WASH, which stands for clean water, sanitation, and hygiene, unsafe sex, and sexual abuse and violence. I would encourage you to go check out the Global Burden of Disease project so you can get a sense of, and you can interact with these visualizations yourself. They're very user friendly, and you can really gain a lot of insights about what the major causes of disease and disability are for a given geographic area. And it's a great way to get a better sense of the burden of disease. So we're going to wrap up with just a few thoughts on emerging infections. So, what are emerging infections? New emerging infections are new, re-emerging, or drug-resistant infections whose incidence in humans has increased within the past 2 decades, or whose incidence threatens to increase in the near future. And if you take a look at a list of recent emerging infectious diseases, some of these will be very familiar to you. You can get an idea of what it is that we're talking about when we are thinking about emerging infectious diseases. And of course, the most recent example is a novel virus, the SARS-CoV-2 pandemic, which began in 2019, is the next emerging infectious disease to be added to this recent list. Um, Also, what is a pandemic? This is an example. SARS-CoV-2 is an example of an emerging infectious disease that has caused a pandemic. Not all of the diseases on this list have, right? Some have, like HIV, for example, and H1N1, but the others did not quite meet the definition of pandemic, which is an epidemic of infectious disease occurring on a scale that crosses international boundaries, usually affecting people on a worldwide scale. Another thing that you see if you look at this list of emerging infectious diseases is that many of them originate in animals, in animal hosts that end up resulting in transmission of a pathogen that is also dangerous to humans and can infect and be dangerous or pathogenic to humans. And the SARS-CoV-2 and all of the human coronaviruses fall into this category. And specifically looking at the SARS-CoV-2 virus, it's thought to have originated in bats and maybe through an intermediate species, the pangolin, ultimately made its way into human populations and began to spread. On the right here, you can see an electron micrograph of the SARS-CoV-2, which is a novel coronavirus and a single-stranded RNA virus. And this is an artist's rendering of the actual virus particle, showing in red here these sort of spike proteins, which are the proteins which are used to make their way into cells where the virus in the human body, where the virus can reproduce and cause disease and infectiousness. This came from one of your readings for this week that shows just some of the different properties of the human coronaviruses as well as pandemic flu from 1918 and pandemic flu in 2009. These relate to the reproductive rate, which is the average number of people that an individual with the infection will go on to infect, and the incubation period. All of these things are sort of relating to epidemiologic properties that help us understand the potential for spread as pandemics in populations. And we'll be covering different all of these different properties and their relevance to infectious disease epidemiology in future lectures. But just to check in about the status of the SARS-CoV-2 pandemic, as of this week, about 25 million deaths or 25 million cases have occurred or documented to have occurred worldwide. We know that it's really quite more than what have been diagnosed because of testing issues and because many cases are asymptomatic. And we also have estimated that there have been about 848,000 deaths that have occurred around the world due to SARS-CoV-2. So just to bring it back to New York City for a minute, and you will recall the trend in the all-cause mortality rate over time and the 1918 influenza pandemic, which killed about 12,500 people in New York City that year. It was estimated to have infected about 500 million people worldwide at that time and caused between 17 and 50 million deaths around the world. And more recent studies are pushing these estimates closer to 50 million than to 17 million. So just to put things in perspective, about the potential for pandemics and their impact around the world. Um, what have we seen with SARS-CoV-2 in New York City? Again, recent data suggests in New York City, about 230,000 people have been diagnosed, about 57,000 people have been hospitalized, and about 23,000 or 24,000 deaths have occurred so far. And just to try to compare this to what we saw in 1918, right? So we have about 24,000 deaths among 8.3 million residents in New York. So far this year, there will be more deaths before the end of 2020. But if we just calculate the death rate now, we get an estimate of about 285 per 100,000 New Yorkers. Comparing that to the 1918 flu, there were about 12,500 deaths among 5.5 million residents at the time for a death rate of 228 per 100,000. So it looks as if this is an epidemic in New York City that has been more lethal than even the 1918 pandemic flu. Indeed, there was a recent paper in JAMA that compared the increase in death over time in 1918, looking at the all-cause death rate, which hovered around 100 deaths per 100,000. And when pandemic flu hit, there was a threefold increase in the all-cause death rate in New York City. And comparing that to what we saw and what we're seeing with SARS-CoV-2, with about 50 deaths per 100,000 over time, an increase to about 200, which is a fourfold increase. So it does look as if this is a pandemic that is even more lethal than what we saw in 1918 in New York. So, what are some of the reasons for why we're seeing emerging infectious diseases more frequently, more new diseases? Well, as we alluded to very early on, a lot of it has to do with mixing of human populations. And over the course of the last 150 years, the time it takes to travel around the world has really gone from about a year when people could only travel by boat to less than a day where people can travel by plane nowadays. And also at the same time, the population growth has been exponential. And so these two things combine to make it possible for someone with an infectious disease to travel around the world, pretty much anywhere in the world, within an incubation period of most infectious diseases, allowing the possibility for spread and seeding epidemics in places where they hadn't occurred in the past. This is a slide from Anthony Fauci that just sort of shows the geographic origin of some of these, an even larger list of emerging infectious diseases to give you a sense of where these things are happening. And we can think about some of the factors that are driving the emergence or reemergence of these infections, right? Of course, the dramatic increases in the volume and spread of international travel and commerce. There's also been a lot of changes in land use patterns in relation to wildlife, and this just increases the probability that dangerous pathogens will be transmitted from animals to humans. There's climate change, there's changes in human demographics and behavior, changes in technology and industry practices. Microbes themselves can adapt to become more pathogenic or more resistant to antibiotics. And importantly, a breakdown of public health capacity at the national, state, and local levels and global levels, thinking about organizations like WHO and PAHO. But you can think about, different scenarios about how infectious diseases will play out in relation to humans over the coming, decades and centuries. A colleague of mine from CDC like to say that in the battle between humans and microbes, all trends currently favor the microbes. They've been around a lot longer than we have, and they probably will be around a lot longer than we are going forward. And so that's sort of setting the stage for thinking about the longer term scenarios. But The mediating factors that might influence the trajectories here include, the public health systems, how good are our diagnostics, the extent to which antimicrobial resistance continues to grow, things like urbanization and population density, the extent to which we degrade the environment and ecosystems, what kinds of availability of vaccines and other preventive strategies might come available, and climate change and also zoonoses. So an optimistic scenario might be one where there are increasingly available effective vaccines and diagnostics, strong health systems, cleaner water, better nutrition, and a process of urbanization and population growth that is a bit more ordered than it has been in the past. And a pessimistic scenario might be, one where there are relative lack of vaccines, poor prevention tools, weaker health systems, and depleted and polluted natural resources and chaotic urbanization. But a few things are certain and some likely, and certainly we're going to see increases in antimicrobial resistance, and new infections will continue to emerge, like we're seeing with the SARS-CoV-2 pandemic. Um, we might likely also see situations where novel pathogens continue to emerge and cause outbreaks as human populations mix with one another and their environments and ecosystems and wildlife. And finally, existing pathogens will emerge in new settings and reemerge in settings where they've previously receded or become endemic. We can expect that these are pretty likely outcomes. Okay, so since we're starting a course on infectious disease epidemiology, I'd like to talk about what's special about infectious disease epidemiology as compared to other fields of epidemiology. So first is that a case may also be a source of infection to another individual and cause subsequent cases. And related to this is that a case may be a source of infection without being recognized as a case. And this is this whole notion of asymptomatic spread or pre-symptomatic spread, which we've been hearing about in the current pandemic situation. Another one is that people may be immune after they become infected or after they receive a vaccine. And this is something that we have to factor into how we understand or predict the likelihood of spread or risk in populations. There's sometimes a need for urgency, and it represents in many ways the roots of modern epidemiology. I do feel like a good foundation in infectious disease epidemiology really does set you up well for learning and being successful in some of the other fields of epidemiology as you move forward in your careers in public health. So I'll just end here with a quote from Jeff Copeland, who was the CDC director when I was there. And he says, as we face the new millennium, we must renew our commitment to the prevention and control of infectious diseases, recognizing that the competition between humans and microbes will continue long past our lifetimes and those of our children. So getting into the details of the course, this course is an introduction to concepts regarding the occurrence of infections and infectious diseases in human populations. Also, epidemiologic methods for studying infectious diseases and approaches to infectious disease control. There was an error in some of the earlier communications about the textbook. It's not, the required textbook is not Nelson and Williams. That one is optional. It's GISEC, Modern Infectious Disease Epidemiology, and a good companion to that is the Control of Communicable Diseases Manual, which is a great sort of reference guide to looking up attributes of epidemiological relevance and clinical relevance for almost every communicable disease. Um, Nelson and Williams is a great book for people who are, know that they're going to be working in the field of infectious disease epidemiology for years and years to come. It's kind of like a Bible in many ways, but it is quite expensive. But that said, it is sometimes the most authoritative source of information. And for that reason, we've included a few chapters as required readings for you in the course, and those have been made available as PDFs for you on Blackboard. There are also required readings every week. PDFs of these are provided under weekly materials on Blackboard. The course will be delivered fully online with most of the lectures being pre-recorded. And these will be made available every Monday. And there are 3 sessions in addition, or there are 2 sessions in addition to this one that will be meeting virtually, synchronously on Blackboard, and the dates are listed here. The next one will be on October 19th, 2020, and the one after that will be on October 26th, 2020, from 8:05 to 9:50 p.m. The instructors are me and Saba Kasmia and Matt Romo. Um, Each week, you'll need to review the weekly material section of the course on Blackboard, and this is where the content. This is where all the content will appear, and it'll be updated at the start of each week. You'll need to complete the weekly readings prior to viewing the lecture, and then you'll view the lecture, complete the weekly assignments, and then you'll be doing weekly posts about the readings and the lecture on the discussion board. The final exam will be completed online. There is no midterm exam for this course. Sorry about the typo. Um, for learning support, you should submit like all your logistical and course questions to the discussion board. There's a separate discussion board that is devoted to questions and answers, and this is going to be the fastest way that we will be able to respond to your questions, and it will also allow your classmates to see responses to the same questions, as they may be having similar questions as you. But for private matters that relate only to individual students, such as grades, these can be raised directly with the course team via email. And I'll post the emails shortly in a few minutes. But for fastest response, please send the email to all 3 of us at once. So on Blackboard, we'll be using these different sections. The syllabus is there. All of the details I'm explaining to you now are available in the syllabus for you to see in much more detail. One thing that I want to emphasize is that you should not submit your assignments with your name on them. Since you'll be submitting them all through Blackboard, they will automatically be linked to you, and we prefer to grade these assignments in a blinded way to increase objectivity and fairness. The discussion boards, as I mentioned, will be there, and the exams will be through Blackboard, and the posting of the grades will be through Blackboard. All of the announcements will be coming through Blackboard. We post them here on the website, and also when we post them, we choose the option that automatically sends them to your emails, the emails that you have registered with Blackboard. So make sure that you're checking those to make sure that you get the announcements in a timely manner. In terms of the grading, there are 5 reaction papers, which I'll talk about in a few minutes, and these are based on the assigned readings, and that accounts for 30% of your grade. There are 2 homework assignments and 2 outbreak exercises that account for 20%. The final exam will account for 30%, and your participation on the discussion board will count for 20%. So what about the reaction papers? So these are 5 papers that are due at different points in the semester, focused on different weekly topics that are, no more than 1 to 2 pages in length, and they're based on the assigned readings for an upcoming session. And so the goals here are that you have the opportunity to convey that you've understood the main concepts and the ideas and the content of the assigned readings, and relating them to some of the concepts that we're covering on infectious disease epidemiology in the lectures and in the textbook. So lots of details here about giving you some guidance about what your reaction papers should include, but they should reflect your thoughts and impressions on the readings, not a regurgitation of the readings or a summary of the readings. They should be synthesizing and critically evaluating some of the theoretical, conceptual, and methodological content of the reading, and identifying some of the themes, how the readings relate to one another, or maybe in some ways they may contradict each other. So treat these readings when you write about them as an interrelated whole, because they are chosen for that reason when you write your paper, rather than a series of unrelated articles. But importantly, please read all the instructions about this on the syllabus. The discussion board, since it's an online course, the participation will be assessed through your post on the discussion board on Blackboard. So each week when there are assigned readings and a lecture, you're expected to go to the discussion board for that week and create two posts in the discussion board on Blackboard. One post will be at least a question and or clarification raised by the readings or the lecture. A second post should be a response to the post of one of your classmates, either answering the questions they put out there or providing your own perspective or commentary on an issue. Posting more than one response to your classmates is encouraged, but it's not required. We view the discussion board as a place where people can share their ideas and begin to explore some of these areas in a little bit more depth and with a little bit more interaction than the online format um, would provide without a discussion board. And the course team will be reviewing all the posts and responding as needed. So again, for this, please refer to the syllabus and the discussion board for more information. So in terms of getting appointments with us, in office hours, just send one of us or all of us an email and asking for a time to meet, and we can set up something by phone or by Zoom. Again, since we're not going to have physical office hours this semester, but here are our email addresses, and feel free to reach out to one of us as needed. So next week is a Labor Day week, and so in terms of our schedule, the next session won't open until September 14th, and you'll be expected to complete it by September 20th. The theme of this next session will be epidemiological, biological, and immunological properties of infectious diseases. So thanks to everyone for making it through this first week with us, and I look forward to catching up with you all soon. Have a great week.